Hello, everyone. Welcome to this new podcast, Pharmacist 1%. I'm very happy to be with Shilpa Patel, that is a pharmacist from the UK. In the first podcast, we talked about the niche of pharmacy compounding. That is a niche that is very important for the future of the pharmacy profession. Now we will talk about the future of pharmacy profession, that is the profession prescription. So we are going to talk about the prescribing pharmacist and how it works, because Shilpa Patel is a very professional pharmacist in the UK. She's been doing this now from a lot of years. She can give you a lot of value in this podcast. So welcome everybody, and welcome Shilpa. How are you, Shilpa? Where are you now?
Oh, I'm good, thank you. Thanks so much for inviting me. Fabio, I'm in Brighton in England. I'm working in a GP practice. I'm actually working from home today, so I'm quite comfortable at home.
Okay. Before introducing you, I really like to tell people what's the story behind your pharmacy profession, you know. So before starting the prescribing pharmacy profession, what's your background? How did you start working in the UK? And how is the UK working in this prescribing pharmacy profession? Because actually this is a very important step that the UK has done so many years ago. And a lot of countries like Italy, it's something that is not available yet, but it's something that Italy is working on. So I really wanted to, that you will say like your story. How did you start working and everything is related to?
Interesting. Yeah, I never think of it that way. We kind of take it for granted here that, we've all had this opportunity. I do shout a lot about it, specifically on LinkedIn. That's probably where you've seen me, Fabio, talking about our prescribing. And I think it's, been a really important part of certainly my career and everyone I'm coming across. It's just completely changed the role of pharmacists in the UK. I've been qualified, I think, about 25 years now. So I qualified in 99 at Brighton Uni, and I've moved to London and I worked all around there. So for the first 15 years, I wasn't a prescriber. I worked in community pharmacy, was dispensing and providing the general services that we provide. Learned a lot of kind of managerial leadership kind of skills as well whilst I was working as a locum, and I worked for Superdrug for 10 years. So I kind of went on this whole community pharmacy journey, and it was only 10 years ago that actually my best friend, she forced me to go and do the prescribing course. I really wasn't interested at the time, and I had too much going on, or I didn't want to go back to uni really. I thought, but what happened was they introduced it to Brighton University, and it was the first year that they were going to allow pharmacists to do it. And so my best friend said, let's get this done. It's the future. And honestly, I wouldn't have done it unless she'd forced me. And I was about to quit the course, I think 3 times, because it's quite a difficult course, and after so many years to go back to university and have to sit an exam and, all of that, it was quite hard work. And I think it was only for the fact that I self-funded, I had to pay for it. I think it was about £1,500, something like that, but 10 years ago. That kept me going, and I thought, I've paid for this, so I've got to do it. But oh my God, did it change my life afterwards? So as soon as I got my prescribing qualification, just taking you back 10 years ago, it wasn't very common in the UK. And so whilst I was doing the course, I didn't really know if I would be able to do anything with it. I didn't know if I'm going to be able to use it. So there was, this whole kind of worry about community pharmacists not being able to use their prescribing role. And then things kind of changed drastically just after that. So 9 years ago, NHS England announced that they wanted pharmacists to help GPs. So there was this big scheme of a big amount of funding went towards funding pharmacists to come and work in GP practices. And I was really lucky to kind of be chosen to be part of the pilot trial for that. So there was a 2-year pilot where NHS England would pay the pharmacist's salary, bring them into GP practice, train them to become prescribers, and take the role of the GP, or like, you know, help with their workload. Obviously, because I was a prescriber already, that really helped me during the interview, and that really helped obviously show that I'm already thinking along those terms. And I got the job, and my life has completely changed ever since. My career's changed, and I've never looked back. It's been a wonderful journey ever since, really.
Yeah, I follow your work on LinkedIn, and it's very interesting because Shilpa, as you will see if you will follow her on LinkedIn, she provides a lot of value with the content, with the daily work of a pharmacist that is completely different how we get used, you know, in Italy. So this is very important for the future of the pharmacy profession. That's why she is here with us today, and it's something that I really believe in, even because I work in community pharmacies as well in the past. So it's very important, not only, you know, helping doctors and everything like that, but also providing value to people, providing value to the pharmacy owners as well, because this is a podcast, you know, for entrepreneurial pharmacies. So as an example, pharmacy owners, but also for pharmacist entrepreneur with entrepreneur spirit. As an example, Shilpa, she's not a pharmacy owner, but she's a pharmacist with a very entrepreneurial spirit. This is something that we really have to see, because if we want to move on, we really have to be entrepreneur into ourselves. So this is very important. One question, Shilpa, that is very interesting, you know, because as an example, in Italy, but in a lot of countries, Master of Pharmacy, it's very all about the technical stuff, you know, and when it comes to start working to the prescribing profession, of course, there is a lot of clinical parts to study, of course, that is completely different compared to the Master of Pharmacy that we study. So that's the second question that I really wanted to ask you. It's about what kind of conditions you can prescribe, and what about the course? It's about 6 months, 1 year, and I really believe that it's very tough, because you have to study things that are completely different compared to the ones that we are used to.
Yeah, I mean, I think that's what was putting me off during my kind of course, because once you've been working in community pharmacy, it's the same here. It's very technical, you know. I think it's changed a little bit now, actually. We're more clinically focused now in community pharmacy. But the first 15 years of my career, I was literally taking a box off the shelf, sticking a label on it, and giving it out. And the only kind of clinical side would be where I was kind of counseling the patient when I was giving it out. But I wasn't having to make these big decisions, prescribing decisions. I wasn't. It was only pharmacists who were really interested in the clinical side who kind of self-motivated themselves to keep the clinical skills up. But a lot of community pharmacists, and especially myself, I kind of more went into the management side, and I was running a very successful pharmacy, but I didn't feel like I was using my clinical skills. The reason why I say things have changed now is because there's a lot more services. So obviously pharmacists are working under PGDs, pharmacists are kind of in a way prescribing things, and there's the services, the medication reviews, that those kind of things have changed things in England. But it's completely different, as you say. There's so much to learn, even during the course. So when you do the prescribing course, it is usually about 6 months. Some courses are 9 months or 1 year. You have every university slightly different. You have to meet lots of criteria. So there's these competencies. They're set by the Royal Pharmaceutical Society and the General Pharmaceutical Council. You have to meet both the criteria from both sectors, and some of the criteria will be consultation skills, understanding antibiotic awareness, understanding how kind of public health works. So you know, there's a lot of that kind of side of things on top of your clinical competencies. So if you decide, so you pick a certain area that you can prescribe in. So for example, with me, my area was sexual health, and I was learning all the medications to do with that. You have to write like a therapeutic review about one medication. So I wrote it about norethisterone, and it's kind of like a dissertation. It's quite, a big piece of work. And so you suddenly jump into this whole kind of new clinical era. When I then joined the GP practice, oh my God, I realized I don't know anything. I literally came in and thought, and being the only pharmacist in the practice, I was being asked stuff. They're, oh, we've got a pharmacist here. How can I change someone from pregabalin to gabapentin or the other way around and things like that? And I was like, well, I know what the box looks like, and I know how many are in the box, and I know what strengths it comes in, but I had just completely forgotten all my clinical skills. And I felt this little, Fabio, and I'm being really open and honest here, but I felt like I'd lost all my clinical skills. And I honestly spent 2 years just reading and reading and reading. And it was suddenly interesting to me because I was seeing problems within, I was seeing patients who who could benefit from me having a knowledge, from me making those changes for them. And I suddenly had all this kind of almost authority. I had a bit more power because I was working in a GP practice. If I spot an error, I can just change it there and then. And it kind of just, this is why I think it changed my career completely, because it's just changed the way I think. I'm so interested in training now. I'm so interested in learning all these things, because when I was a community pharmacist, if I learned the difference between gabapentin and pregabalin and how to switch over, I wasn't able to actually put that into fruition. Like I wasn't able to make that change for the patient. Whereas here, I can have a patient in front of me and I can actually, whether you're a prescriber or not, you can make that change, or you can get one of the doctors who is sitting next door to make that change for you, or a different prescriber. But once you become a prescriber in your certain scope, so like I mentioned, I was a prescriber in sexual health. As soon as you retrain and get enough kind of competencies within another scope of practice, you can self-certify to say that you're competent to prescribe in that area. And you do have to kind of show that you have to kind of demonstrate that you've done enough training, but actually it's just a self-certification at the end of the day. So over these 10 years, I am now able to prescribe in every single area. So I'm prescribing, benzodiazepines, controlled drugs, morphine, the lot, whatever is needed. And most of my pharmacists, so I work in a surgery. We employ 11 pharmacists at my surgery. So it's quite a big surgery, but we are, I believe we're the only surgery in the country that's got 11 pharmacists. So I'm really proud of that. And I'm always shouting about that, Fabio.
Yeah, that's great.
But I'm really kind of promoting the pharmacy profession. But in our surgery, most of us are prescribing, and most of us are prescribing in all areas now. There's not many areas that we're not prescribing in. And, a really easy one is to add on is hypertension, because that's something that pharmacists find quite easy. And then kind of lipid management, and that's usually a next step. And then after that, you just kind of grow and grow and grow. And between us all, where we're working so close together, we learn off each other, and we've got a really secure, kind of safe kind of environment. So we're all just kind of, every single pharmacist just keeps increasing and increasing their scope. So there's probably about 5 of us now that are prescribing in all areas. And I think one of the things I might mention here is that everything I've learned in the last 10 years, I've kind of put that all on my website. So I've got a website called askshilpa.com, and I just share everything on there. It's free for anyone to access. But I suddenly one day realized I'm learning so much, and it's all very GP clinical focused. So I've just been putting everything on there, and that helps me to train new pharmacists. So whenever a new pharmacist comes in, I've got the protocol, I've got everything that you need to know to be able to run a certain clinic in the surgery, and they'll just have that open. So for instance, I might have a whole section on gout. So how to diagnose gout, how to treat it, what monitoring you need to do, what, in primary care, what you need to do. And if one of my pharmacist has got that page open and reads it again and again before each gout review they do, by the time they've done 6 or 7 gout reviews, they know that off by heart, and they're able to kind of apply that, and they feel really confident because that's kind of taken nice guidelines into consideration. The BNF guidelines is kind of everything that I've learned over the years. So we've got, a really nice structure set up to be able to kind of expand that scope. But yeah, I had to kind of study for a good 2 years to kind of get up to date on everything and feel quite confident that I could have an impact in the GP practice. And now I think it's taking pharmacists about a year from when they come in till they're quite confident in all areas. And that's because we've got this structured program for training pharmacists now.
You give a lot of important advices, and actually you introduced a very important topic that is related to give to the pharmacist authority, because unfortunately a lot of community pharmacists are too much commercial, and a lot of pharmacists are behind the counter. They are seeing from the customers like salesmen, Of course, a company must sell in order to survive, in order to pay salaries, in order to grow, of course. But it's important that the pharmacist must be the pharmacist. So a very professional guy that is an expert, not only about technical stuff that a lot of times it's useless. It's more important the clinical parts, because if the customers, if the patients asking you information and you are not very prepared on this, you're only being seen as a salesman, So it's something that you introduced, and it's something that gives to the pharmacist authority. So it's very important. So another important thing that you introduced, it's about the study. Of course, people must study a lot, because we are talking about something that you're pretty much shifting from technical part to clinical part, So if the pharmacists think that, I can be a prescriber one day, it's not easy as you think, because you really shift a lot of things that you are doing now that is pretty much a technical work to something that is a clinical work as a doctor, that you are pretty much sitting in your study, in your room, and you're providing prescription to patients. So this is very important, because unfortunately a lot of people want to do things, but they don't know that they have to pay a price for that. You have to sacrifice, you have to study. This is very important. In the previous podcast with another doctor, another pharmacist, that is Dr. Tommaso Pelagatti, is one of the most prepared compounding pharmacists in Italy. He talked about this. He talked, if you really want to reach ambitious goals, you have to study. This is important. So Shilpa told this, and this is something very important. So you really have to pay the price if you want to reach ambitious goals. And so this is something that I really wanted to mention also in this podcast. Shilpa, I think that you agree with this, of course. You pay the price for being at what you are now, because you studied a lot. It's something that you're doing for since a lot of years. So I think that you share this topic,
I mean, I think it's very individual. It depends on the person. So you get some people who love the clinical work, who really crave it. They go into community pharmacy and they think, oh, I'm not doing what I trained to do, or I used to call myself a glorified shopkeeper when I was there, because I was spending just as much time selling sandwiches and top-up cards as I was dealing with medication issues. And again, I just want to keep saying this, it was very different 20 years ago. In the last 10 years, community pharmacy in UK has become much more clinical, but there's still a lot of pharmacists who aren't thriving. I think there's more kind of satisfied pharmacists. I'm meeting people who are actually able to use their clinical skills within community pharmacy. And I do believe very soon we'll be able to use our prescribing skills within a community pharmacy setting as well. GP practices are kind of struggling, and pharmacists during COVID, community pharmacists were really recognized. They did a really amazing job. And I think it was the first time that the rest of the country thought, oh, we've got these community pharmacists who could be delivering services, who could be kind of upskilled. And I don't know if you know, Fabio, next year, all the students who come out of university will all be prescribers. So they've incorporated the whole prescribing course into our normal kind of degree course. So every single student who comes out or every single pharmacist that qualifies will be a prescriber. They're all going to go into community pharmacy, and they're going to want to use their prescribing, or they're going to assume that they're going to use their prescribing. So all the community pharmacists that I've trained, so I'm a DPP, which I'll talk about in a sec, what that actually means. But I'm like a supervisor trainer, and I've trained about 33 pharmacists so far. Wow, and those pharmacists are all from community pharmacy, but they've all gone back into community pharmacy and they're not using their prescribing. They don't know what to do with it. They don't there's no kind of system for it just yet. And I think it's just going to need one or two to just kind of start something, and it's going to start a revolution. And all the community pharmacists are going to be using it as well. At the moment, anyone who comes and trains and becomes a prescriber, they all end up going into a GP practice, because that's where you really, you can use it day in, day out. The problem with that is we're stealing all the pharmacists, all the, especially the good pharmacists. They're all being taken away from community pharmacy. They're all being brought into GP practice, which is causing quite a problem, as you can imagine, in community pharmacy. And just going back to the DPP, so when you go to university now and do your independent prescribing course, you have to spend some time with a supervisor, a clinical supervisor, and that's called a DPP or a DMP. So used to be a doctor, so they were called a designated medical practitioner. So when I did my training, I had to sit in with a doctor, and it's for 90 hours. You've got to do it. So you shadow a doctor for 90 hours, you do consultations, you kind of get to actually experience kind of the whole
so you work closely with them,
in their room.
In the same room, you work closely with the doctor.
Yeah. So it used to only be a doctor, and I'd say about 6-7 years ago, they changed it. No, it must be about 5-6 years ago. They decided that any prescriber can be this supervisor. So as soon as that happened, I became a supervisor. And so now pharmacists can sit in with me for 90 hours and I sign them off. So there's a lot of assessments to be done. So they have to be able to do consultations. They have to be competent within their kind of prescribing area, and I absolutely love doing it because it teaches me a lot when I'm training them. It makes me review our processes. I train in lots of different areas, so I do a lot of hypertension training, and it makes me really kind of question how we're delivering our service. I do ADHD training, I do mental health training. So every new student that I get, I spend time with them and I teach them kind of the whole process, and then I get them to run it. So by the end of the 90 hours, they are able to run a clinic of their own. So they get really good kind of, they have to do this, and they get good training within.
It's mandatory, of course.
It's mandatory, yeah. So I'm getting a lot of community pharmacists coming in asking for this, because everybody's really worried about being the only non-prescribing pharmacist left, so there's hundreds of pharmacists wanting this kind of support.
Yeah. What about I have seen, I remember I followed the previous Prime Minister of the UK. I remember I've seen a YouTube shorts where he described the Pharmacy First program, but this is something different compared to the things that you mentioned, or it's about the same thing?
So Pharmacy First is probably, you're definitely right. So when I said during COVID, community pharmacists suddenly were recognized, I think that's why he brought out the Pharmacy First program. Pharmacy First is a program where you can go to your pharmacy and you can be diagnosed for certain conditions, but it's quite restricted, so they can only prescribe a certain amount of things. It's restricted in a way, but it has been successful in many areas as well. So the aim is for patients to go to the pharmacy first, see if these conditions can be treated. So, for example, an insect bite, a urine infection. So they're all kind of minor illnesses. And if the pharmacist, so they've got we call them PGDs, which is kind of like a direction, like a protocol that they follow. And as long as it meets all this criteria, they're allowed to give the patient a prescription only medication. So they're in a sense prescribing. So that's kind of the first step towards prescribing. And so it's services like this that I think have made community pharmacy much more clinical already in UK, where we've also got PGDs for like weight management as a separate thing, not as part of Pharmacy First. But there's a company called Doctor, and they are really good at writing these PGDs, and they've been kind of rolling it out all around the country. And they are kind of encouraging pharmacists to provide all these kind of services. So you can go and have a weight management consultation, and you can have an injection prescribed for the treatment of weight or to help with weight loss. There's also other PGD. So there's travel vaccines. We can prescribe the travel vaccine now, and we can inject. I've been away from community pharmacy for a while, so I can't remember all the services in community pharmacy, but that's kind of the way it's going. So these are all prescription medications that you couldn't get in a pharmacy before.
I remember I read a list of conditions that your pharmacist can do a prescription directly in the pharmacist, and there's no need to go to the doctors. So this is a very important step as well. We have 5 minutes left, and I wanted to ask a simple question that is related to how it works in the daily job. As an example, a patient enters into a pharmacy, and then see, as an example, the counter with the pharmacist behind. But of course, I think that when it comes to doing diagnosis and then you have to do a prescription, I suppose that there is a separate room for doing this. As a doctor, I think you can confirm this. So, as an example, is something that pharmacists can do behind the counter. How does it work in the daily job?
So quite a few years ago, it was well before COVID, a new rule was brought in, and all UK pharmacies have to have a consultation room, and that rule has kind of been implemented. I don't think there's any pharmacies in the country now that don't have it. Some have now gone the next step, and they've got 2 or 3 even consultation rooms. And so we've had consultation rooms in community pharmacies for at least 15 years now, I'd say, or maybe even 20 years. So all that was all kind of in preparation for all these services. So if you wanted to run a prescribing clinic in your community pharmacy now, which people are starting to do, it's very easy. It's very easy, kind of that side of things to set it up. I think there's just more of a kind of a fear because it's not very common, so people aren't quite sure if they can do it. Whereas because a lot of pharmacies are now pharmacists are working in GP practices, it's completely different for us because we have got a GP room. We can see patients. We've got a lot of support around us. We've got the doctor next door, or we've got a nurse or some kind of clinical lead. And we've also got a team that we can instant message all the time, and you've got a lot of it feels a bit safer in a way because you've got so much support, whereas in the community pharmacy you're kind of always on your own. It's just the pharmacist who's kind of got the last say. So there's a slight difference there.
Great. So what do you think about and why it's very important that both pharmacy owners and pharmacists as well must implement this in the daily job? We talked a lot about this, But if you should say one thing about this, what would you say as an example for the pharmacists? Could be something for getting paid more, for providing more value to people, or as an example to pharmacy owners that are struggling with the incomes, they can add a new service for adding incomes and providing energy to their company. So what would you say about this? Is it something that must be implemented in the pharmacies, and it's very important, right?
Mm. Oh, definitely. I mean, there's no doubt about it. It's got to go down that way. I'd be really surprised if it didn't. And pharmacy owners who don't kind of get involved are missing a trick. I think it's both the things. One is income. NHS income from prescriptions is completely, it's been dropped so many times. It's just been decreased and decreased. There's no way you can survive in a pharmacy by just, dispensing medication anymore. You have to get involved in the services. And it's really lucrative. There's so many different options because you can go private, so you can provide lots of private services, or there's NHS services as well. So they're funded by the NHS, and you have to kind of meet certain criteria and apply for these services. So you've got both options. NHS services are easier to get patients to sign up for. So once you've got an NHS service, patients, don't have to pay for it, or it'd be heavily, heavily subsidized. And the other side is the private services. So I think pharmacies are slowly going to become the place that provides the most amount of private services. And that's the only way forward to actually make a pharmacy viable. And on the other side, you've got the fact that everyone's becoming prescribers. All these new pharmacists are going to come out as prescribers. They want to use their skills. It would be a complete untapped resource if you have a pharmacist there who's a prescriber and isn't able to use their prescribing qualification. It just wouldn't make sense to.
Absolutely, yeah, I absolutely agree. Signori miei, il podcast è concluso, un podcast di estremo valore come sempre. Siamo qui a portare dei contenuti che veramente credo forse non siano mai stati portati in Italia, quindi abbiamo visto oggi quella che è la seconda nicchia che riguarda il futuro della farmacia e dei farmacisti, quindi il farmacista prescrittore, come funziona ormai da moltissimi anni in un paese che è il Regno Unito, e come questo è fondamentale che venga integrato anche in Italia. Quindi contenuto di estremo valore, riguardate questo video, cercate veramente di capire come funziona il tutto. Mi auguro che venga impostato il tutto anche in Italia al più presto, perché è un ruolo di fondamentale importanza se vogliamo implementare tutto quello che è il settore farmacia a un livello avanzato. Quindi farmacista 1%, secondo episodio concluso. Grazie a tutti e ci vediamo alla prossima. Buon lavoro a tutti. Ciao!